Hello, my name is Kaylon Taylor Clark, and I have the honor to be the moderator for today's briefing. My background is in health equity. I'm thrilled to be here as a member of the board of Healthy Women, but also in this briefing that is so very important to women's lives. The first thing I'd like to do is introduce Beth Battolino, who is the CEO of Healthy Women, to provide us some opening remarks. Beth?
Thank you, Kaylon. Hi, everyone, and thank you for joining us for our latest policy briefing, which will focus on new research plans for women's health and their potential to transform women's healthcare. And thank you to Healthy Women's Corporate Advisory Council for sponsoring today's briefing and for their ongoing support of our mission. For those who don't know me, I'm Beth Battolino. I'm President and CEO of Healthy Women. Healthy Women is the leading independent nonprofit health information source for women. And for more than 35 years, we've been dedicated to educating midlife women so that they can make informed health decisions, advocate for themselves, and prioritize their health and wellness. At Healthy Women, we know all too well that women's health is not just breast and reproductive health. It is the whole head-to-toe health of women. While women make up more than half of the United States population, there's still not enough research and data on women's health, leaving major gaps in knowledge about how various conditions specifically impact women. The good news is that thanks to the hard work of many, such as the esteemed lineup of expert panelists we have here today, there has been a significant push to close those gaps. By focusing attention and funding on health areas that solely disproportionately or uniquely affect women across the lifespan, we've been able to make progress in not only reproductive health, but autoimmune disease, brain disorders, cardiovascular disease, and cancer. New government efforts have been made in the past year to galvanize women's health research, develop innovations to address gaps, and to ensure that all women have access to quality care. My friend and colleague, Dr. Kaylon Taylor Clark, is here to moderate the conversation about this important work. Kaylon, over to you.
Thank you so much, Beth. So to begin, I have the incredible pleasure of introducing our congressional host, Congresswoman Lauren Underwood from Illinois' 14th Congressional District. We are so honored to have her join us today. She's a rising star in Congress and leads many important initiatives to ensure patients, and especially women and people of color, are heard, valued, and cared for in our healthcare system. She's a registered nurse with master's degrees in both public health and nursing, and the Congresswoman has been a leading voice on health policy and a passionate advocate for health equity for both women and minorities. She's the co-founder and co-chair of the Black Maternal Health Caucus and also introduced the landmark 13 bill set known as the Momnibus Act in 2021 to address the alarming maternal mortality rate among Black women. The Momnibus was reintroduced in 2023, and over $200 million in new Momnibus and maternal health funding was enacted through the appropriations process. She also led the Providing Urgent Maternal Protections, PUMP, for Nursing Mothers Act, a bill to fix a legal glitch that denies basic protections to millions of working moms who need to express breast milk while at their workplace. These are just a few examples that illustrate how Congresswoman Underwood champions women's health in Congress. Her commitment to health equity and to making women's health a national priority is unparalleled. Thank you so much for joining us today as we address the current and future state of women's health in America. Welcome, Congresswoman Underwood. It is amazing to have you with us live this morning.
Well, good morning, everyone. Thanks so much for having me. My name is Congresswoman Lauren Underwood, and I'm excited to be here with you all. I represent Illinois' 14th District in Congress, and I serve as the co-founder and co-chair of the Black Maternal Health Caucus. First, I want to extend a special thank you to Healthy Women for hosting today's briefing and their longstanding work to serve as a resource for women. And thank you to all of the wonderful panelists for the work that you all are doing to advance women's health and research. It's time to fundamentally change how our nation approaches and funds women's health research. Women make up half of the United States population, but for far too long, a lack of timely research and data on our health has left providers without important tools to diagnose and treat millions of women with debilitating conditions like endometriosis and fibroids. That's why investing in women's health research is vital, because when women are healthy, we have healthier families and healthier communities. This is one of the reasons I've worked so hard in Congress to introduce legislation like the Endometriosis Care Act, which invests in endometriosis research to find real solutions to address this debilitating condition. But that's not all. Our investment in women's health must go further because for many women, their lives depend on it. The United States has the highest pregnancy-related death rate of any high-income country, and it's only getting worse. Over the past 2 decades, maternal mortality rates more than doubled and disparities worsened. The causes are multifaceted, and we cannot end the crisis without a comprehensive response. So this year, I was proud to reintroduce the Momnibus alongside my friend and Black Maternal Health Caucus co-chair, Congresswoman Alma Adams, and Senator Cory Booker. The Momnibus is the most comprehensive legislative solution to the maternal health crisis. It's a sweeping package of 13 evidence-based bills that address every driver of maternal mortality, morbidity, and disparities in America, including the lack of maternal health research. As my colleagues and I have been working in the Congress to get the Momnibus passed, we have also made great progress. Through the fiscal year 2024 appropriations process, we secured more than $100 million. $100 million in funding for Momnibus priorities. And that's on top of the $100 million we secured last year. These appropriations wins include funding for HBCUs and minority-serving institutions to conduct maternal health research, as well as funding for community-based organizations to deliver maternal health support services. Since 2019, the caucus has also worked tirelessly to secure robust funding for maternal health research and ensure that those dollars are used to focus on areas that are both critical and often overlooked. In our first year, the Black Maternal Health Caucus met with Dr. Francis Collins, who was at the time the director of the National Institutes of Health. And we explained the need for maternal health research, and he got it. After that meeting, NIH pulled together separate funding streams into now what's called the IMPROVE Initiative. It stands for Implementing a Maternal Health and Pregnancy Outcomes Vision for Everyone. In the last 5 years, the Black Maternal Health Caucus has increased its funding for the IMPROVE Initiative 5-fold, reaching $53.4 million in the most recent federal funding package. With this funding, the IMPROVE Initiative has supported critical life-saving research. They've stood up 12 maternal health centers of excellence around the country, and they've launched a tech challenge to improve maternity care, and so much more. Despite its critical mission, the initiative lacks sustained authorized funding, and that's why Senator LaFonza Butler and I introduced the NIH IMPROVE Act to authorize permanent funding for the IMPROVE Initiative and ensure continued funding for this essential maternal health research. We are exploring every opportunity to get this legislation passed this Congress, and I know that together we can get it done. I look forward to continuing to work with all of you to make sure that future investments in research and health include women from every background and every part of our country. Thank you so much for having me, and I'm really looking forward to celebrating with you when we can get all of these bills across the finish line. Thank you.
Thank you so much, Representative Underwood. That was wonderful. Now I'd like to take you through some of the data that are so important to women's health. I think they're going to come up in a moment so we can speak to them. So what is women's health? What we recognize is that women's health are conditions that solely and or disproportionately or differently impact women's health throughout the lifespan from head to toe. Next slide, please. And the question is, of course, why does it matter? We know it matters because women are 51% of the population and yet remain underrepresented and underfunded in health research. 30% of women are affected by sex-specific diseases. That's 45 million people. 80% of autoimmune patients are women, 8 million people. 66% of Alzheimer's patients are women, 5 million people. Ovarian cancer is the only sex-specific cancer with 50% mortality rate because we have understudied women. Women are 2 times more as likely to die from a heart attack, which is nearly 200,000 people per year compared to men. And 1 in 5 women felt that their provider ignored or dismissed their symptoms. That's 30 million women. They don't hear us. They don't hear our pain. And this has to change. Cancer is also diagnosed 2.5 years later in women than in men. These are the kinds of statistics that we can no longer live with. And this is why the work of Representative Underwood and the folks that you're going to see on this panel today are so very important. Next slide, please. Let's talk a little bit about women of color. It turns out that Black women are twice as likely to die from uterine cancer as white women. Women of color are also 41% more likely to die from breast cancer, despite having similar or even lower incidence rates of breast cancer. That's a really important point. 60% of Black women 20 years or older have cardiovascular disease. Black women are also 3 times more likely to die from pregnancy-related conditions than white women, and this is something that Representative Underwood spoke to us a bit about. And Black women face disproportionate risks of cardiovascular disease, as mentioned, hypertension, stroke, lupus, as mentioned, and other cancers. This is unconscionable and needs to be addressed immediately. With the work of Representative Underwood and the others that you'll hear from today, this is something that we're hoping to overcome. Next slide, please. So what's the current state of women's health? Well, we know that there's a lack of investment, lack of government funding, leading to limited private investment. Only 2% of all venture capital money is going toward women's health. 2%. 90% of investment decisions are made by men. And frankly, that has to change. And of course, investors are going to be looking more like folks like myself and Representative Underwood and be thinking more about how we can balance these investment decisions. And only 4% of all biopharma R&D, which is about $2 billion of the $101 billion that's spent on R&D in pharmaceutical and device companies, are going toward women's health conditions. We want to change that, and we hope to change that with the advocacy and the work of the folks that you're going to be hearing from today. So what's the opportunity? Well, women comprise 80% of healthcare decisions of their families. So they are ready to hear what we have to say, and they're ready to get out there and advocate not just for themselves, but for their families. They spend 18% more of out-of-pocket spending, excluding maternity care, which is absolutely unconscionable. How do we get that out-of-pocket spending down? They have 33% more provider visits, and the economic benefits here are 60%. They are 60% of the paid workforce and 65% of the unpaid workforce. We have to improve women's health, which makes women more productive and therefore lifts society. And that is what we're hoping to do, not just through this congressional briefing, but through the work of all of the folks, both on this line, as well as the folks that you'll hear from today. Next slide. So I now would like to introduce Dr. Jenica Patterson, who's the portfolio lead of the Sprint for Women's Health and Project Accelerator Transition Innovation Office. That is quite a lot to say. PATIO is easier, and ARPA-H. Dr. Patterson, now to you.
Great. Thank you so much. I'm so honored to be here today to talk a little bit more about who we are at ARPA-H and also talk a little bit more about what is the Sprint for Women's Health and where we are in that as well. So if you go to the next slide, I first want to focus on who we are as ARPA-H. And I want to say that's important because everyone on this call can help us make a difference at our agency. There's a lot of unique and innovative ways to work with ARPA-H. And I hope a big message here after I finish my presentation is you learn the ways to work with us and you identify ways that we can really make a difference. So I first want to start with our mission. So ARPA-H's mission is to accelerate better health outcomes for everyone. And I'm going to tell you how we do it, who we bring on to make it happen, and what we're looking to do. So for how, so we're a unique funding agency by design. We have unique structures and legal authorities that allow us to function more like a business where we can work quickly, nimbly, and decisively to meet our mission. Who helps us bring our mission to fruition within our agency? Well, we hire term-limited government positions, they're program managers, to be able to come up with problems that they believe really could catalyze a field. So they come up with those toughest challenges in health. These program managers come in for 3 to 6 years to help solve these hard problems, and then they leave. And this is very intentional. It's because it helps in the inflow of new ideas within our agency. The ARPA-H you see now, right at this time, is going to look completely different when you come and learn about our agency in 5 years. And that's done, again, by design to bring in those new ideas, those new flows to our agency. And what? We are really seeking those radical changes in health. We look at our investments to make sure that we are seeking and addressing some impossible barriers in health, demonstrating proof of concept for solutions, and really transitioning those out into the hands of people to meet our mission. Our program managers that we bring in have a lot of autonomy. We call it full contact management. They work with the teams that they bring on and fund to maintain that vision and deliver results in a timely manner throughout their program and throughout their tenure that they're here at ARPA-H. Ultimately, our success is really defined by real world impact. We really want to meet our mission. We don't define our success by publishing papers or patents. We define it by reaching people out into the world. And that I'm going to show you a great example of how we're trying to do that with the Sprint for Women's Health. There's a lot of ways that you can work with ARPA-H, like I mentioned. I'm going to provide some QR codes in a few slides, but quickly, I can just mention them prior to this slide. You can become a program manager. So if you are on this call, you're looking for your next new exciting job, come become a program manager at ARPA-H. Make that radical change. You could submit your idea to a program or to an open innovation solution opportunity. I'll show that QR code in a moment. Or you could also become a spoke in our ARPANET-H network, where there are opportunities to network across the United States and the world, as well as to receive funding potentially on particular projects. But now on the next slide, I'm going to focus on our unique program model that we launched in February to use some of the elements I just talked about to really solve hard problems in women's health. So in February, we had the honor of the First Lady announcing the Sprint for Women's Health. We committed $100 million to catalyze this field. We have 2 funding tracks that we were looking at. We had a Spark Award. What if we could spark an idea in women's health? It's really focused on those early stage R&D efforts. And we had a Launchpad track, which is a $10 million award. What if we can really accelerate later stage R&D efforts, something that has a proof of concept that we can reach out and put out into the market in 2 years. We have 5 program managers step up across our agency to really help galvanize this field. The 5 program managers are on the right, including myself. We came up with 6 different unique topics to tackle the charge in women's health, from women's health at home, looking at ovarian health across the lifespan, looking at new unique models, in vitro models for women. looking at advancing brain health via the lymphatic system, looking at taking women's pain seriously, looking at objective and quantitative measures of pain, as well as looking at everything else. That would be topic 6, that was mine. Maybe those 5 topics didn't reach an idea. Those topics came to me. We really wanted to focus on 3 things here. We wanted to address the gaps in women's health. We wanted to catalyze the ecosystem. This is a beginning. This is an end to a beginning for ARPA-H. We also wanted to test a new business and contracting model. We wanted to maximize the authorities that we have at ARPA-H to really lower the bar for non-traditionals to work with ARPA-H, as well as the traditionals that typically do. If you go to the next slide, I'm going to talk a little bit about where we are in the sprint. Like I said, we started in February. We launched our program. We had our our actual solicitation launched to the world in March. This is how efficiently and quickly we work. We received evaluation or applications in April. We down selected from 3-page solution summaries to pitches in June. We had folks pitch to us in July, and now we're in negotiations. So we are at the point where we are looking to see who we will award. So stay tuned for that announcement very soon. Just to give you a brief status update, we had an unprecedented number of submissions from 45 states, including DC, and 34 countries. We didn't even know 34 countries knew about ARPA-H, so that was very exciting. We had a mix of scientific visionaries that submitted to our sprint across the globe and across health sectors. And the really exciting part is 50% of those submissions came from organizations with fewer than 50 people. That's unprecedented for the government. Now we're in the selection of candidates. So again, we narrowed down those 3-page abstracts to in-person VC style pitches. That's a very unique model for the government. We brought on an array of subject matter experts to support our program managers in those to make better informed decisions. So think women's health experts, equity experts, regulatory experts, reimbursement experts. And now we're in negotiations, and we hope to announce soon our awards for the sprint. And I just want to mention here that, again, we're coming to an end of this process for awards. And again, this is an end to a new beginning. It's really exciting for us because we get to actively manage these awards. We get to actively make a difference in women's health. It's going to make a huge impact across all ages and stages in women's health. Next slide. And if you have your phones, I just want to wrap it up here and say, we want you to engage with ARPA-H. You are how we make a difference. Submit your project idea to our innovation solution opportunities. Become a program manager. Collaborate with us. Understand what we're launching. Keep up to date with our Vitals bi-weekly newsletter. There's a lot of ways to engage and be part of our mission to really catalyze the ecosystem. So thank you. I'll hand it back over to the host.
Thank you so much, Dr. Patterson. That was wonderful. And I hope people were able to download that QR code. Now I'd like to introduce Ms. Seileen Mullen, who is the Deputy Assistant Principal Secretary for Health Affairs at the Department of Defense. Ms. Mullen, on to you.
Good morning. Thank you to HealthyWomen for inviting me to speak here today. Sorry, trying to get the lighting here is a little rough. Sorry about that. So next slide, please. Okay, just want to give you an overview of what the Department of Defense and that the women look like. In the military health system, we take care of more than 230,000 active duty servicewomen, nearly 2 million female military beneficiaries and retirees. Women are the fastest growing population in our, as we recruit and retain. And so we have been pivoting for the last several years on trying to make that reflective in our research areas. Next slide. So as many of you know, the White House put out an executive order on women's health research. And so these are the specific sections of the actual act and what we've been doing to mirror that and to follow suit. We've been doing much of this for years, but really put sort of pedal to the metal and have been doing these 4 areas. So I'm going to talk a little about how we're integrating women's health research, how we're prioritizing investments, galvanizing the research in women's midlife health, and then how we're assessing unmet needs to support women's health research. Next slide. All right, so how are we doing this? First, thank you to everyone on this call who represents Congress. Every year, the Congressionally Directed Medical Research Program provides a huge variety of funding opportunities for us. And so a lot of areas that affects women's service members are Alzheimer's, multiple sclerosis, lupus, orthopedic, and musculoskeletal injuries, and other certain, as I mentioned earlier, specific cancers. These funds will be used on research topics to include rheumatoid arthritis, and chronic fatigue, just to name a few. We are also adopting a new sex as a biological variable policy that will apply to relevant research funded through the CDMRP starting October 1st, 2024, which of course is the new fiscal year. We are also standardizing the CDMRP and other MHS research funding opportunity announcements to encourage applicants to consider research on health areas that are important to women, that affect all women, and we are committing DoD Small Business Innovative Research Program and Small Business Technology Transfer Program to increase its investments in supporting innovators and early stage small businesses engaged in research and development on women's health. Next slide. So what are we doing with our partnership with our other executive agencies? One of them, obviously, we follow very closely what ARPA-H is doing and within HHS. And then, of course, we work very closely with DoD and VA. And so we have established a joint collaboration with the Department of Veterans Affairs to improve women's health research. And DoD's new military Women's Health Research Program with Dr. Lynette Hamlin is being appointed as the first ever dedicated Director of Women's Health Research Program. Also, to further our collaboration with the VA, the Health Executive Committee, which I co-chair, established a joint DoD and VA Women's Health Research Collaborative Charter in 2024, which will explore opportunities to promote joint efforts to advance women's health research and improve evidence-based care for service members and veterans. Additionally, the collaborative will increase coordination with the goal of improving care and care delivery across the lifespan of women in the military and women veterans. The collaborative will also advance research in key women's health and develop a roadmap to close pressing research gaps, including those specifically affecting service women and women veterans. The department ensures our providers are trained in gender-specific care. Through the VA-DoD Women's Health Working Group, 2 mini residencies are held annually to help provider proficiency. The VA-DoD Women's Musculoskeletal Mini Residency and VA-DoD Women's Mental Health Mini Residency offer healthcare providers from both departments opportunities to learn about the latest research while strengthening skills and knowledge area, how to assess, diagnose, and treat service women and female veterans. The VA-DoD also developed a Women's Midlife Health Concerns Working Group to develop a needs assessment tool that will be deployed to women veterans and active duty service women to gather their input on their midlife health concerns, including menopause and cardiovascular health. This group will make recommendations and develop tools to build provider proficiency in appropriately assessing and treating midlife health concerns. Next slide. Over the last 5 years, the Uniformed Service University of Health Sciences, which is our medical school, has sponsored 76 grants and produced 32 presentations and 152 publications specific to women's health research. USU has also established the Military Women's Health Research Consortium to develop and guide best practices for the clinical care of women in the MHS. Recent research focus areas include studying interventions for physical and emotional pain due to uterine fibroids, evaluating disparities in treatment of women with low back pain, and studying the effects of prenatal mental health support intervention. Next slide. The DoD has taken actions to ensure that women's health is considered throughout the research application process. For example, CMRP, USU, and MHS research programs have all included standardized language in their FY24 funding announcements to encourage research on women's health, including consideration of sex and socioeconomic factors. The Defense Health Agency's Small Business Innovation Research and Small Business Technology programs are congressionally mandated programs established to increase the participation of small businesses in federal research and development. These programs enable DHA to spark the development of future technology to improve warfighter health and survival. DHA, CIBR, and CIDR revised the DoD broad agency announcement, the funding mechanism utilized for these programs to encourage participation in innovation and entrepreneurship by women. Additionally, to enhance investments in applied research and practice focus on women's health, CIBR and CIDR have requested women's health research topics from stakeholders as part of the FY25 broad agency announcement development process. Next slide. About 8% of the women serving an active duty force are of childbearing potential. Providing the full spectrum reproductive health care for women is a priority of the MHS. Walk-in contraceptive services, including comprehensive contraceptive counseling, are available at all of our military hospitals and clinics. Earlier this year, the department also added O-pill, the recently approved over-the-counter contraception, to the uniform formulary. Pregnancy and delivery account for almost a quarter of all hospitalizations for women in the military. The incidence of severe maternal morbidity is significantly lower in the population of women served by our military health system than in the U.S. population in general. And that's because we capture people right at the beginning. Ensuring active duty service members and other beneficiaries are aware of the available resources is just as important as expanding access to care. The department continues to add information on health.mil, including a full listing of walk-in contraceptive service locations. Additionally, the department developed 2 free mobile applications to provide and educate the understanding of reproductive choices. Expanding reproductive autonomy is critical to meeting the needs of active duty service members, as well as recruiting and retaining members of our armed forces. This month, we will provide a report to the President on the status of the implementation of research and data standards following the executive order. Members each submitted a report to the directors that identify the funding needed to catalyze research on women's health. Lastly, in collaboration with USU, we are working on planning a Women's Health Research Initiative celebration coming up in the next month. I thank you all very much for allowing me to speak today and appreciate the opportunity. And I will turn it back over to our moderator.
Thank you so very much, Ms. Mullen. Really informative. So now I have the honor of introducing Dr. Catherine Rexrode, who is the Chief of the Division of Women's Health in the Department of Medicine at Brigham and Women's Hospital and a Professor of Medicine at Harvard Medical School. Dr. Rexrode, on to you.
Thank you so much. And it's really an honor to be here today, speaking and educating all of us about how to improve the health of women. I come with a perspective as a physician, a primary care doctor who takes care of women, as well as a researcher who has spent the last 30 years trying to advance the health of women in cardiovascular disease. Next slide. So as Kaylin Taylor-Clark and others have outlined, it's important to think of women's health across the entire body. We know that every single cell in our body has a sex and that this affects every organ system and very diverse aspects of health. And the unmet needs in women's health research include health conditions that only occur in women, endometriosis, as Representative Underwood discussed, and others, polycystic ovarian syndrome, fibroids, infertility, so many conditions, premenstrual syndrome, menopause, we could go on and on, that occur only in women. And many of these have been drastically underfunded in terms of research. But there are also many conditions that affect women disproportionately or affect women differently, disproportionately, such as autoimmune diseases, conditions that affect women differently, such as cardiovascular disease, my area of research. And many of these have been understudied and under-resourced for women. Next slide. In terms of health conditions that are affected by sex and or gender, there's a very large swath that affect women disproportionately. And I'd like to call out that many of the major causes of disability for women occurring in working age women are particularly understudied. Arthritis conditions, premenstrual syndrome, menopause symptoms, endometriosis, fibroids, conditions of pain, and mental health. And then there are many that affect women differently, and a number that affect only women. Next slide. So where are the gaps as we think about women's health moving from research into clinical care? So we have a big gap to close on knowledge and research in women, and how the health of women is affected differently. We've underfunded many areas, and we need to fund them so that we can expand that knowledge to understand how diseases are different in women. In terms of data, we have often not presented or required data to be examined by different groups, looking at outcomes in women versus outcomes in men. And for instance, in terms of drug side effects, serious adverse drug effects are much more common in women. However, we haven't always had to have drugs show that or report differences in adverse effects in women versus men. For clinical trials, presenting data by women and men so that we can aggregate that data and understand, are there differences in how we should be interpreting data that we receive, so that we can best inform the health of women. In terms of healthcare delivery, there are sort of two different kinds of gaps. One is the knowledge gap that Seileen Mullen was describing in some of the DoD efforts in terms of helping clinicians, physicians, and other care providers have the information they need to accurately be able to treat and help women, whether it's the perimenopause or it is how cardiovascular disease is different in women. And then we need to be sure that healthcare access is ensured for women, and that includes being able to be covered for that care in terms of our policies towards insurance and healthcare coverage, as well as having available clinics near to them. And then finally, a lot of this is underpinned by investment, and women's health has been underinvested for a long time. And many of these solutions, including the data, the research, and the integration into the companies and delivery systems that will make a difference, is also needed. Next slide. So I'm a physician who takes care of women and has studied cardiovascular disease, heart disease, and stroke over my career. And I'm going to focus just on heart disease and stroke as an example for how across the entire spectrum of care, we need to think about what's different in women and how to address that. So as for men, heart disease is the leading killer of women in the US, but there are many risk factors that are different in women, such as an early menopause, pregnancy complications like preeclampsia and preterm delivery. But none of these have been thus far included in our cardiovascular risk estimators that we use in clinical practice. And that's because there's been a data gap in applying this. So we know there are risk factors. We don't know how to translate them into clinical practice. We know that there are delays in diagnosis for women with heart disease. In the ER, women with chest pain wait up to 29% longer than men, and they're more than 7 times more likely to be misdiagnosed with missing a heart attack and being attributed to, let's say, reflux or anxiety rather than a heart attack. Those gaps can be closed if we institute protocols where every individual, for instance, with chest pain, has a standardized way of being assessed, including something like an EKG and a biomarker test such as troponin to eliminate some of these gaps. Women are less likely to be admitted to the hospital after chest pain or referred for catheterization, areas, again, where we can move from data into implementation. And we need to do these things to address the fact that currently outcomes are worse for women after heart attack or after coronary bypass surgery. And we need to close those gaps They're less likely to receive the standardized treatments, medications before discharge, for instance, and that's a gap that can be remedied. Next slide. One of my main areas of research has been stroke. And again, I just want to think through this spectrum where there are differences in risk factors, both how common they are, how strongly they're associated with stroke. For instance, diabetes is a more powerful risk factor for stroke in women than men. And then these sex-specific factors, such as the hormonal factors, pregnancy complications, and early menopause. We talked just briefly about diagnosis. In stroke, women are less likely to receive a complete evaluation and, similar to heart disease, more likely to be misdiagnosed. And then in terms of treatment, they're less likely to be given the clot-busting drugs that can break up a stroke. And importantly, across all of these health diseases and conditions that we're talking about, women have been underrepresented in clinical trials. And so for cardiovascular disease, heart disease, and stroke, although women are as likely to die as men, or it's the leading cause of death in both men and women, in most cardiovascular trials, women comprise only about 30% of subjects. And as for heart disease, there are worse outcomes for women after stroke, a higher rate of disability, meaning that they're unable to perform things that they were able to before their stroke. And women, there are a larger number of stroke deaths per year in women than men. But I think very few people appreciate that, or it has not driven our research thus far. Next slide. So if we focus on women's health, I just want to stress that it has this incredible positive impact on the economy because of the ways in which, if we can address this suffering and disability in women, it will lead to better well-being, more engagement in the workforce and in families, improved societal outcomes, and has a stronger economic outcome. Of course, I think there's a moral imperative for this as well, but in terms of the big picture, there are huge benefits to improving the health of women. Next slide. So how do we go from funding for women's health care? And I am so encouraged by the efforts that have been put forth as we discussed today, the work of Representative Underwood, the effects from the White House Women's Health Research Initiative. Those have not yet fully translated in less than a year or two to impacts on health. But how does that happen? Well, once we can translate the research into these health outcomes, we can improve the quality of life for women, reduce their death from specific conditions, and hopefully decrease the severity. And that has huge societal cost benefits, reducing nursing home costs, reducing the caregiving that is also predominantly provided by women, increasing the ability to be a part of families and our labor force. Next slide. So if we think about where we are now and where we want to be, how do we improve the health of women? Well, from my perspective, investing in women's health research is a foundation for that. For diseases only affecting women, such as endometriosis and maternal mortality, and diseases that disproportionately or differently affect women, such as cardiovascular disease. And that means across all of the organ systems, across all of our institutes and agencies. Additionally, we need to collect and report sex-specific data to evaluate the impact and effectiveness of different interventions and treatment. We need to increase access to women-specific care, from prevention to treatment across the entire lifespan, through adolescence, through midlife, where there's been a big gap in attention, and through older age. And then we need to implement policies to support women's health, and that applies to insurers, employers, medical schools, and other healthcare professional training, as well as to our research institutes. So I'm so encouraged by the attention that this is now receiving, and for being a part of this conversation today. I'd like to thank you, and I look forward to the discussion.
Thank you so very much, Dr. Rexrode. That was wonderful. And we're looking forward to the panel discussion with you. I'd like to just now produce some key takeaways, some summaries that we heard today. That bottom line is healthier women lead healthier families, healthier communities, and a healthier nation. We know that the externalities of focusing on women's health are immense. We also know that women are 51% of the population, and they comprise over 80% of household purchases and medical decisions. They are the key drivers to making our society healthier. We also recognize that only 1 to 2% of all venture capital investment is in women's health innovation, and we must do more to bring innovations to the table that will help females and women. Sex differences go down to the cellular level. We know that. Yet medical decisions are based on clinical trials and data generated from the study of male cells with limited racial diversity. We must do better. And we can do better with increased government and private sector funding for women's health and biological research, with the inclusion of women in the research process. And I cannot see the bottom of my page, but it is all going to be very important that we obtain the most for women that we possibly can. I'd like to now, if we may, turn to the panel so that we can have some open questions before we depart in the next 15 or so minutes. And the first question will actually go to Dr. Rexrode, if we may. So maybe we can open it up to see everybody here. Great. Hello, Dr. Rexrode again. Thank you. Hello, Ms. Mullen again. Great. Thank you. So we're going to actually start with Dr. Rexrode, although I have a feeling that others of you may be able to answer this question. The question is, when will we start to see the benefits of increased government funding, the increased government funding that you noted at the end of your talk, and focus on women's health? Is this prioritization also trickling over to the private sector?
So such a good point. I do know that the White House Women's Health Research Initiative also targeted this public-private partnership. And I do think we are starting to see a change in, we now have a phrase of femtech. I think, we should understand that all tech should apply to both men and women. And there are areas where women have very much been overlooked. So I do think in drug development, in thinking about new solutions, in thinking about technological solutions, the private sector is moving. In terms of funding to, clinic, let's say, as was outlined for the ARPA-H proposals, it takes almost a year to award funding from the time people apply till they actually receive funding, or at least 6 months. And then that data has to be generated. But I do think that there is so much focus on taking the knowledge we have now and translating it into advancing the health of women, and then trying to accelerate that timeline from research to care delivery. So I believe we're already building some of that response, but we also have to realize that it takes years to fully complete that cycle of proposing a study, gathering the data, and having robust answers that will lead us to continue to improve health. So we have to both be excited and patient, I guess, is the answer.
100%. That's what we deal with in pharma all the time, so I appreciate that. Ms. Mullen, I know that you have to leave, but we did have one burning question for you, which was how has the President's executive order on women's health focused DoD efforts in this space?
Well, I'm a political appointee, so I would like to say that when I got in this seat 2.5 years ago, I would already had turned to focus on that. So as far as I'm concerned, the White House is catching up with me. But anyway, I would say, one of the few things we've done right from the beginning is when we put out our research priorities, is I put women's health in the top 3. So I would say we have been on that road, and I really appreciate every year the amount of money that the Correctly Directed Medical Research Program has been putting towards that. We have stakeholders and advocacy groups from the women women, primarily in the areas, and have been for decades, on the areas of breast cancer, uterine cancer, and other things. I would say that what they've helped us do is really helped us on the data and the science and the collection of that, and being uniform across all the other agencies as well, making us look at sex as a biological factor. I don't think, we think, well, hadn't thought about that. So we really appreciate the guidance we've gotten from the White House on these efforts. And I'm sorry I can't join to the end. I gotta run. I gotta get to the Hill.
Completely understand. Everybody's very busy,
Believe
but
me, I'd rather talk to you all.
Thank you. Thank you so much
you.
for being here. We really appreciate your participation. Have a
Thank you.
great day. And we have one more question actually for Jenica, Dr. Patterson. Given the breadth of innovation demonstrated in the Sprint for Women's Health, what are you most excited about in the future of women's health research?
Thank you for that question. I think generally right now, I'm looking a little bit immediate of what we're going to fund and what we're going to do in the next 24 months. I think what's really exciting about our sprint is that we have a diversity of innovations in terms of early R&D efforts. So maybe something that didn't exist, maybe we will make it exist in 2 years. Or our later stage efforts, what if we can actually launch these innovations into the market in 2 years? And that's really our goal. So I think what I'm looking for in the horizon is, in the next 24 months, what mountains can we move in women's health to really make a difference? And what areas can we catalyze? So maybe it's us breaking through that ground, and then our other colleagues at DoD, at NIH, and others can help us carry that forward. So that's really what I'm looking forward to.
Thank you. Thank you so much, Dr. Patterson. So I think for both panelists, we'd love to open up the next question, which is, what do you think needs to be done to ensure better bedside care for all women? Maybe we'll go ahead and start with Dr. Rexrode.
Sure. So I can think of it as gaps in knowledge, gaps in education of the caregivers at the bedside, and then I guess gaps in delivery systems. So on the knowledge side, again, we need the foundational knowledge that comes from research to understand how we should be thinking about health in women, and training then our generation of nurses and physicians and other caregivers in the healthcare system to be able to deliver that knowledge. And that's been a hard thing to remedy. Someone brought up in the questions, what about menopause care and training? And, that's been under-taught in medical schools, for instance, for a long time. And so there's a big catch-up that we need to have. So I think those are the strategies we need to pull together and synergize in order to truly change the care at the bedside.
Wonderful. Thanks, Dr. Rexrode. Jenica?
Yeah, and I'll follow it up in terms of the sprint and in terms of implementation. So with the unique awards that we will be funding. So we had a great opportunity from Congress. We had 3 locations that we have at ARPA-H. One is in DC, one is in Boston. It's our Investor Catalyst Hub. I mentioned ARPA-H. One is our Customer Experience Hub, which is located in Dallas, Texas. And the reason why it's important and answers this question is we are looking to bring our innovations in terms of the IDEO framework and feasibility, breaking through the technical barriers, in viability, making sure it's viable into the market, but also desirability. So making sure it's desirable to customers and others, and how it can be implemented further. So our Customer Experience Hub, we are working with them closely, and we're bringing in experts in other augmented R&D efforts for our Sprint for Women's Health to make sure areas like this will be implemented into our awards. So it's kind of a unique model where we bring the experts into us to help us implement and make sure that these innovations are desirable to the person that's going to use them, and also the person that maybe is going to apply them to that user.
And I think I'm just one more question, Dr. Patterson, I'll go to you first, is what coordination do you think needs to happen between government and the private sector to make us succeed?
Absolutely. I think we thrive here at ARPA-H on public-private partnerships. That is one reason why we have our Investor Catalyst Hub and our Customer Experience Hub. One unique part of our Investor Catalyst Hub is making things viable. We are really into the market, so we're really looking for what is that next phase for our awardees to be able to be successful. And I think it's a lot of the building those public-private partnerships from the government out into the market for them to be successful. So we are constantly working on that. If you know anyone that's an investor or that is a funder in this space, we ask you to point them to the Investor Catalyst Hub, become a spoke, because then you can learn more about making a difference here with us at ARPA-H.
Public-private partnerships, so very important. Thank you, Dr. Patterson. Dr. Rexrode, did you want to end with any last comments on this question?
Just to reiterate that there is a huge market potential in this area. We can hear from the discussion today how many areas are ripe for innovation and new public study startups and other responses and infusion of venture capital. So I am hoping that the market sees these early changes and recognizes the huge potential in this as we take science and translate it into clinical care and delivery. And there's so much to be done on that private side.
Thank you, thank you, thank you so much, Dr. Rexrode. Thank you, Dr. Patterson. And we want to thank Ms. Mullen, although she's here, she's off doing other things very important to what we're talking about. We really appreciate your participation today. I'm now going to turn it over to Beth for final closing.
Wow, what a great conversation. Kaylon, thank you for a beautiful job moderating today. We got to hear about the importance of investing in women's health, its ripple effects across the women's health ecosystem, and the actions that Congress can take to continue making progress for women everywhere. Thank you so much to our esteemed speakers and panelists, Ms. Seileen, Mullen, Drs. Rexrode and Patterson, for your perspectives as experts in the field. And last but not least, thank you to our Corporate Advisory Council members for being willing to invest in the health of all women. It is because of you that we're able to continue to advance women's health. Thank you.